And thanks for kind of staying late for this talk before the break. So I want to talk to you about some new technologies that have appeared for endocrine surgery over the last couple of years. The first one I want to talk about is parathyroid autofluorescence. In early 2000, it was serendipitously discovered that if the parathyroid glands are subjected to certain wavelength laser, then they emit autofluorescence, and you can detect it with cameras. And as you can see on this graph, that let me see. Okay, let's go back here. Okay, I see it. You can see that the brightness of the signal that we receive from the parathyroid glands are much higher than the thyroid and the background soft tissue. So this opened the door for further investigation. The intraoperative setup is that you have this camera connected to a generator, use a sterile cover, and then you can then turn the lights down and look at the surgical field, and you're trying to look for a bright signal that might represent a parathyroid tissue. So if you look at thyroidectomy procedures, what benefit could such a technology, almost like a night vision technology, have? It can potentially show you the parathyroid glands early before the dissection, so then you might be more cognizant to preserve them, knowing where they're located. And then you could also look at your specimens before sending them to pathology to see if you have incidentally removed a parathyroid gland that is going to pathology by mistake. If you're doing parathyroid implantations, you can make sure that you're actually putting in something that's really parathyroid tissue, not soft tissue. And as it has an FDA-approved label as an aid for parathyroid identification, maybe instead of doing frozen section when you're in doubt, you can use this technology to rule out parathyroid tissue. And if you look at, we've been doing as a group a lot of research on this over the past 10 years. And if you just look at the number of parathyroid glands you can identify with this technology before they become apparent to the eye, it turns out about 1/3 of the parathyroids actually you can locate their fluorescence before it catches your eye. So this can guide your subsequent dissection. And then just looking at the thyroidectomy specimen before you're sending it out, you can actually, it can increase your ability to identify these glands. And when we looked at a couple of different studies, they're actually able to bring down our incidental parathyroidectomy rate by just reviewing the pathology results. Just kind of showing you a case, and how much you use it depends on kind of how much you want to incorporate this into your technique. Now I do my procedure 100% autofluorescence guided, and this patient had multinodular goiter. We are on the right side, and just before I do any dissection, I look to see if I find any parathyroids. I couldn't see visually, but with the fluorescence, we are seeing a couple of bright signals there. And the lower and upper are actually parathyroid, and this is a thyroid cyst. And then this guided my resection of the thyroid, and at the end of the procedure, I was able to preserve these glands. They have a nice flow as well. And then on the left side, again, just before doing any significant dissection around the parathyroid gland and the nerve, then kind of use this camera, and then you can see two parathyroid glands also showing up. Not each case you can see them all like this, but this is an example that it can kind of help identify these glands, maybe facilitate the dissection because you know where they are, and you have a better chance of preserving them, knowing where they are ahead of time. And these are the glands that have been preserved at the end of the procedure. And then before we send out the thyroid to pathology, we're also going to look at it and to make sure that there are no parathyroid glands on the thyroid specimen like this. And this has been a standard step in our procedures nowadays. Just takes about, every time takes about 30 seconds to a minute, depends on how kind of facile you get with the technology, but I don't see any bright signals here. And if you were to see a bright signal, this is how it would be. This is a thyroid, and then I see that there's an incidental parathyroidectomy there. And using this technology increased my awareness of finding the gland, and then we implant it into a sternocleidomastoid muscle instead of sending to pathology. But the thyroid cyst can be a false positive, as you can see here. And then with the parathyroid implantation, you can see these glands appear very bright even when you're implanting. And we did actually published a study that even a couple of years after you preserve these glands with cryopreservation, they maintain their fluorescence. So this is pretty fascinating. And at the end of the day, the question is like, you have this fancy tool, but does it really improve your outcomes or not? So the early research really kind of went very enthusiastic, and they looked to see if you could decrease your hypocalcemia rate. But identifying these glands doesn't mean that you will be able to preserve their vasculature. So the data from the studies have been conflicting. And then because it is tough to do a study on long-term permanent hypocalcemia, these studies have focused on temporary hypocalcemia, and the results have been variable, and these are a couple of the randomized studies that have been published, and the results have been conflicting. Some of them have documented some improvement in temporal hypocalcemia, and the other ones have not. And when we looked at our experience, although it decreased our incidental parathyroidectomy rate, it didn't really decrease the post-op hypocalcemia as expected. And then the difficulty that we will probably never know the answer whether it really decreased your hypocalcemia rate permanently, because you would need about 35,000 patients in each group. So just kind of putting this information aside, so what we can actually measure is objectively, how often do you send these unrecognized parathyroids to pathology? And within our group, we did a study where we used this technology in 300 patients, and we compared to historical 750 patients who had thyroidectomy without using this device. And incidental parathyroidectomy rate using this technology was 13%, and without using technology was 23%. And it was related to the fact that we were able to increase our ability to see these glands, so we are recognizing more glands that were at risk, and then auto-transplanting them. And then, as you see, in the autofluorescence arm, we had 11% implantation rate versus 4% in the non-autofluorescence, because we could not see these glands. And if you actually add these together, that kind of puts you about 30%. These are the glands at risk during a parathyroidectomy operation. And then how about Graves' disease? And when we looked at our experience with that as well, although they did not see differences in hypocalcemia rates, the benefit regarding decrease in the incidental parathyroidectomy rate was more pronounced. It went down from 30% to 12.9%. Seems to be adjunctive intraoperative tool for parathyroid identification, and depending on how much you want to include this in your technique, but it can be incorporated into a conventional thyroidectomy technique without really prolonging the operation, because each time you use it, it can be done in like 20, 30 seconds. But I think the objective benefit seems to be more in predicting location of the parathyroid glands before dissection and identifying those glands at risk for incidental removal, rather than making really bold statements about decreasing hypocalcemia rates. Next, I want to talk about the thyroid RFA. Again, over the last couple of years, in addition to autofluorescence, thyroid ablation has been a kind of a new technology that we've been exposed to. In Korea, this was introduced in the 2000s, which kind of relies on the principle of using radiofrequency ablation needle to kind of create these burns inside the thyroid nodule. And we've been watching this technology from a distance, and early 2000s we knew about this technology, but over the last years, really good quality research started coming from Korea, and then a couple of really custom companies that produce thyroid specific technologies and antennas came into the market, and then this actually then increased awareness, and with the patients also being informed about this. This became a reality in the U.S. over the last couple of years. Just a disclosure, this is a technique, this is a procedure that is 100% requested by the patient. So we don't really go to the patients and say, actually let's ablate your thyroid nodule, but these are the patients who show up in your office asking to have their thyroid nodules ablated, And the primary determinant is that they don't want to take thyroid medications. So every patient tells you this. And regarding the consensus and guidelines, the Koreans actually have done a lot of work on this. And their guidelines have included symptomatic thyroid nodules, including those that cause cosmetic problems, and autonomously functioning thyroid nodules with their tumors with the nodule size about 2 centimeters. Because when we looked at the literature about there are other guidelines in the literature, the Europeans also have some more data on this, and Australians as well. But generally, they mention about 2 or 3 centimeters. They're kind of cutoff for indications for this procedure. And last 2 years, kind of seeing that patients that have been asking for, we started the program. We treated close to 50 patients so far. And when you look at the literature, multiple prospective and randomized studies have done, and then they've reported volume reductions. And they use the volume. We'll kind of touch upon on that. And then if you take the volume calculations over 6 months, they report kind of consistently 50 to 80% decrease in the volume. And over the last couple of years, a few other centers have also started this program. And 2 years ago, the American Surgical, actually, the University of Tulane group published about 200 patients. And then they showed that over time, there was significant reduction of the nodule volume. And we've treated about 50 patients so far, and our indications have included patients with larger than 2 centimeters symptomatic or enlarging thyroid nodules with a benign FNA. We've recently also included patients with Bethesda 3 or 4 with benign firma as well, after really good discussion with the patient. Toxic nodules, and the patients who are poor candidates are really refusing thyroid surgery. As I mentioned, these are all coming from the patients, and we really don't really actively market this procedure. We're doing this procedure in the operating room now. We tell the patient if something goes wrong, that they get their consent to do a thyroidectomy at that time. We use local anesthesia, rarely sedation if needed, so anesthesia on standby. And then in a couple of hours, the patients are sent home from the recovery room. And this is kind of how the procedure looks like. You create these burns within the nodule, making sure that you're not burning any of the critical structures. So we don't really burn the whole nodule, but we burn the inside of the nodule by leaving a rim of safety around the nodule. Then we see these patients 2 weeks, 3 months, 6 months, and 12 months. Deliberately did this follow-up to really see the natural history of these nodules after treatment, and we also give them an objective symptom questionnaire that have been developed at our program as well. Just to give you an idea, looking at the first 25 patients, again, these are just your usual patients that you see. Half of the patients had a single nodule and half multinodular goiter. And in this cohort, the old patients had normal thyroid function. I think we only have 2 patients that we have treated with autonomous nodules at this time. These have to be solid or predominantly solid. If they're completely cystic, you cannot do the procedure. And a few patients we operated with indeterminate FNA, but a benign firma. The ablation time median is about 15 minutes, and the in and out time from the operating was about 40 minutes. And again, most patients just need local anesthesia. A few patients have required sedation, and only 1 patient required general anesthesia. We haven't had intraoperative complications. And a few patients had pain, bruising. But what I would really call complications is that 1 patient had cellulitis, and then 1 patient had the thyroid nodule rupture. Most of these patients come in because they have all these symptoms, and sometimes, well, how could these symptoms be related to your thyroid? But when you look at the improvement of these symptoms, and I'll show you some, that these symptoms have improved in the patients, and the nodules really shrink in size. And there's kind of some examples. This is pre-op, and this is like 6 months, and then just this is kind of a volume, and this is kind of the size. When you get about 50% reduction, means that if you have a 4 centimeter nodule, it goes to maybe like 2.5, 2.8 centimeters. So the volume is a little bit kind of an illusion. I think it's used in the literature, but you can get at least like in the largest dimension, more than a centimeter decrease over time. These are some other examples of these nodules that shrink over time. And let me go to this. And we've also noticed that kind of when you look at either nodule volume or the largest dimension, you really establish a decrease over time. And these also correlate with the patient's symptoms as well. When we look at this prompt questionnaire, and then over time we see that the patient's symptom score really goes down, and these are different type of symptoms you can see here, and over time we've seen that their symptoms get better as well, and the symptom relief is positively related to the size or the volume reduction over time. So in our early experience, the data shows that in symptomatic benign thyroid nodules, RFA could be effective in alleviating the symptoms by reducing the nodule size in appropriate patients. We suggest really incorporating the objective questionnaires to really objectively evaluate the symptom relief. I really want to thank our endocrinology colleagues, Dr. Leah L. Hage, Dr. Mikhail when she was here, because they really screen the patients and then kind of refer the patient to if they think that the patient is a good candidate. I'm going to stop here, and any questions we could answer. Thank you.